Good evening, everyone. Welcome to the Snyder Institute for Chronic Diseases Mini Medical School Lecture Series. We are pleased to host a presentation and discussion this evening on the topic of measles. My name is Hannah Riley, and I will be the program host for this evening. Before we get started, I would like to go over a few housekeeping items. There will be two parts to tonight's program. First, each of our presenters will speak for approximately 20 minutes, and then we will open the floor to audience questions. We will take a 10-minute coffee break between each speaker, and refreshments will be provided to those of you here in person. You are welcome to ask your questions at any time during the presentations using Slido. To access Slido, you can scan the QR code or type www.slido.com into your browser and manually enter the event code Snyder MMS into the participant field to post your question. Questions submitted to Slido will be viewable to all audience members, and participants can upvote the questions they would most like to see asked. Now onto more specific housekeeping items. For those of you that have joined us online, if you lose your internet connection and drop out, you can return to this session using the same Zoom link you used to join us now. If you experience any technical issues, such as you cannot hear or see the presenters, please email snyder@buxa.com and our team will do their best to support you. For those of you here in person, we ask that you now switch your cell phone to silent mode. Please note this event will be audio recorded and the recording will be posted on the Snyder Institute website and YouTube channel. Private recordings are not permitted. To formally begin our program, the Snyder Institute at the University of Calgary's Cumming School of Medicine, located in the heart of southern Alberta, would like to acknowledge and pay tribute to the traditional territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, comprised of the Siksika, the Piikani, and Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, including the Chiniki, Bearspaw, and Goodstoney First Nations. The city of Calgary is also home to the Métis Nation of Alberta Districts 5 and 6. I'd now like to introduce our moderator, Dr. Craig Jenny, who is the Deputy Director of the Snyder Institute and a professor in the departments of Microbiology, Immunology, and Infectious Disease and Critical Care Medicine. He also holds the Jessie Bowden Lloyd Professorship in Immunology Research. Dr. Jenny's research uses intravital microscopy to study the early innate immune response to viral and bacterial infections. Now I will hand things over. Take it away, Dr. Jenny.
Thank you, Hannah. It's wonderful to see a huge crowd in here tonight. This is, I think, the largest we've had in this room this year. So I appreciate you coming, particularly given it's 15 and sunny and May, and there's some sort of hockey game thing happening. I know everybody will be checking on their phones, so if you get really excited, just, cheer all you want. This is a fantastic opportunity tonight. This is our wrap up of our 10th season. So 10 years of mini medical school. I've had the privilege of being one of the presenters a few times. This is my first opportunity to moderate, which means I get to stand in the shadows and watch the other guys sweat the questions, and I can just enjoy my evening, have coffee and mingle. I think tonight's topic, when we planned this a number of months ago, we had no idea how timely this would be. So probably could not have had the timing better with the provincial announcements this morning of enhanced vaccine clinics and clear messaging on the value of vaccination and the severity of measles. So tonight we'll see some of that information. We'll see how viruses actually work, how the body fights them off, as well as how the disease or the infection impacts Albertans and Canadians. So we have two wonderful speakers tonight. To start things off, we traditionally start with a little bit more of the basic science research. And tonight I have the pleasure of introducing Dr. Andrew Leidal, who is an assistant professor in the Department of Physiology and Pharmacology and a full member of the Snyder Institute. Andrew is known for his expertise in viral immunology, looking at how our body cells respond to being infected by a number of different viruses and what mechanisms we use to defend ourselves against these. In particular, Dr. Leidal studies the role of aging in these responses. So why is it some of us fight off viruses really well, whereas others are at higher risk of severe disease, and simply how that's related to age? Dr. Leidal trained at the University of Toronto and Dalhousie University in Halifax before moving on to the University of California at San Francisco. So a fellow alum from there. I'm sure we've probably been in a number of the same establishments near campus. You do that while the experiments are running. I mean, you got to pass the time somewhere. Dr. Leidal's research has been cited more than 3,500 times, and he's a recipient of a number of national and international awards, including the Banting Fellowship, the Award for Next Generation of Scientists, and Longevity Fellowship from Google Calico, and the California Institute for Quantitative Biology. So with that, it's my great pleasure to introduce Dr. Leidal.
Thank you, Craig, for the very kind introduction. I'm really glad that I had the opportunity to speak to you guys tonight. And if I weren't here, I would be watching the Leafs game as well. So today we're going to be talking about measles, but just before we get into that, I'm just going to show you a little bit of my history, and Craig went through it briefly, but I started out in Toronto where I learned to study things less than a cell, molecular biology and genetics. This is largely because I was too small to play hockey, and my hockey career never really blossomed, so I decided to hit the books. After that, I developed a passion for viruses, and so I went to Dalhousie to study cancer-causing virus called Kaposi sarcoma. Subsequently, I moved on to UCSF, where I learned about how cells defend themselves against viruses using a self-eating or Pac-Man-like approach, where they can actually chew up the virus inside the cell and degrade it down to its most fundamental components. And then now I'm here at the University of Calgary and have to become a Flames fan. And I'm using what I learned prior and studied to understand how respiratory viruses infect cells, how cells defend against them, and how this affects inflammation. Now, as Craig pointed out, it's very timely that we're discussing measles, and so I'm going to go through a few points that kind of present an overview of the whole presentation. The first being that measles is an infectious disease caused by a highly contagious airborne pathogen, and that's the measles virus. And it remains a considerable cause of childhood disease and death throughout the world. And in fact, last year alone, there was approximately 100,000 deaths globally due to the measles virus. And this is dramatically reduced compared to in the 60s, when vaccines weren't available and when greater than 2 million passed away from infectious diseases related to measles, the measles infectious disease. So infection can result in a number of diverse symptoms and outcomes. In mild cases, it can lead to fever, cough, a runny nose, red eyes, which are kind of common to all viral infections. But as the virus incubates and grows and replicates, it can give rise to kind of some unique symptoms, including white spots in the mouth, the mucosa, called Koplik spots, as well as a distinctive rash that starts around the head and neck and then around the trunk of the body. And that's usually about 4 days after you develop your kind of runny nose and fever. And that rash lasts about 7 to 10 days before it kind of resolves. And that's in a kind of a mild situation, but there are lots of severe complications that can result from infection with measles, including pneumonia, blindness, ear infection, diarrhea, adverse pregnancy outcomes, and severe neurological conditions, as well as death. So the final point is that actually immunity to measles virus, either through vaccines or through prior infection, profoundly reduces the risk of subsequent infection and adverse outcomes. So this is relatively new data. I understand this is possibly updated this morning, but I generated this slide a couple days ago. But what it shows is the distribution of measles cases in this most recent outbreak in Canada. And you can see here that in a number of provinces, including Ontario and Alberta, there's more than 100 cases that have been detected in 2005. Almost 1,000 in Ontario alone and 120 here in Alberta. And in the last week alone, 69 in Ontario and 37. In proportional to the population, it seems like it's maybe somewhat decreasing in Ontario and possibly increasing in Alberta. So this shows you the historical incidence of measles in Canada since 1998, where we actually thought the virus was eradicated. But you can see every few years we get this crop up of infections, with the most recent year providing the bulk of those. In fact, well over 1,200 now and counting. This kind of pattern, the development of this pattern kind of goes with import of the virus from other places, as well as kind of lapses in immunity in the population from either vaccine reductions, as has occurred because of the COVID pandemic and failure to kind of people get vaccinated. But also because of people kind of being somewhat complacent about the virus because we've got it solved, and now we maybe don't need, and so it kind of steps to the background. And so in the most recent statistics, this shows you the number of patients, kind of their age groups that have been affected. Most predominantly, this is younger individuals. As you said, it's a disease that often affects children. And there's a few more older patients as well that have developed the disease. Only 2% of the cases seem to have been imported, but these could have been the cases that helped start the most recent outbreak. And most of the ones in Canada are kind of epidemiologically linked, meaning it's being transmitted within Canada itself. Greater than or about 82% of the individuals that have come down with measles were unvaccinated individuals, whereas 2 and 4% are those that received 1 and 2 dose. And finally, as always with measles, you can see that the hospitalizations related to the disease hover around 5 to 10%, which have been observed in the past. As I said, with millions of infections, we've got very good epidemiological data about the proportions of people that will need to be hospitalized during a measles outbreak. So these are the critical statistics, probably the ones that people are really most interested in. And that is things related to the virus itself. How does it affect me? What kind of disease can I get from this? What are the rates? 90% of those that are exposed to the measles virus and lack prior immunity to it will develop measles. 3 in 10 that are infected with the measles will experience complications. Most commonly, this is ear infections and diarrhea, but occasionally they become more severe. For example, 1 in 20 will develop pneumonia. 1 in 1,000 will suffer from measles encephalitis, which is brain swelling or inflammation. And 1 in 25,000 will develop a very devastating disease called subacute sclerosing panencephalitis, or SSPE, which actually will develop in people 6 to 15 years after their infection and is lethal. Overall, roughly 1 in 300 people will die from measles. And I put up here a picture of the Ronald Dahl book, the BFG, or the Big Friendly Giant, which was actually dedicated to his daughter. He's the author of Willy Wonka and the Chocolate Factory and James and the Giant Peach. So he dedicated this book to his daughter, who actually passed away here on the left from measles encephalitis, this rare but very devastating disease. So what makes measles nasty? Why is it a nasty virus? And you can see a picture of, this is the measles virus here. It's got a membrane around it. It's got a couple things called proteins on the outside of it that are kind of like the fingers that it uses to touch cells. And it's got, this is its genome. That's where it encodes the things that take over cells. So measles is highly contagious and airborne, and it infects cells in our lungs. That means we'd inhale it into our lungs from the air outside. It's actually one of the most contagious viruses known to man. 90% of people exposed that don't have immunity will come down with measles if they're exposed to it. Measles can survive in the air for 2 to 3 hours, and this is amazing. It's got amazing stability in the air. That means if you're on a bus and someone had measles, coughed it out, left the bus, you got on the bus 2 hours later, you could actually come down with measles. Another important feature of measles, it has a very long incubation period. You get exposed to the virus and you actually start to develop your fever and symptoms almost 2 weeks later. So you start to develop a rash, coughing. At that point, it seems like any other virus, and you maybe don't take precautions. But 4 days later, you'll start to develop this rash, which is distinctive of measles. And so in that period, you're really shedding all this virus, exposing people, not knowing that you're actually carrying this really infectious disease. And that results in many people getting infected. In fact, measles, being one of the most contagious viruses out there, can actually result in 12 to 18 people being infected per one infected patient. So one person can infect 12 to 18 people, which is called its replication number. In contrast, flu, another virus that we're really familiar with, it only infects generally 1 to 2 people for every person that gets infected. The other aspect that makes measles nasty is it infects and replicates in a broad spectrum of cell types, most notably immune cells that are present in the lung. So this virus, like all viruses, it binds to cells, it goes inside them and turns them into factories to pump itself out. To do this, the measles virus actually uses a protein, this finger on the outside called hemagglutinin, which it uses to recognize the cells that it wants to infect. It specifically recognizes, sort of like a lock and key, a receptor on the surface called SLAM or CD46. Then this other protein or this other finger helps to basically import the virus into the cell. At this point, the virus replicates itself over and over and over millions of times and comes out. This virus can also infect other cell types besides immune cells, including structural cells of the lung, blood vessels, lymph nodes, and other organs via a receptor called Nectin-4. And this is into cell types, including epithelial cells, endothelial cells, and fibroblasts. The final aspect of this portion here of this talk that makes measles nasty is that the immune cells that it infects, including the dendritic cells, lymphocytes, macrophages, they actually migrate around the body. They're not just stuck in the lung. They get infected and then they start to move. And that allows those cells to spread the virus to other organs in the body, including the liver, the lymph nodes, spleen, skin, which gives the measles type rash, as well as the brain contributing to encephalitis. So it's important to note that there's a Canadian connection to actually measles and measles research. Two people that I actually know very well. One, Dr. Chris Richardson at Dalhousie University, was actually on my thesis committee. He discovered one of the 3 receptors, or actually 2 of the 3 receptors involved in measles virus infection. He discovered SLAM as well as Nectin-4, and his student, who I was a student with at Dalhousie, discovered Nectin-4, and he's currently now at the University of Alberta. So Canadian virologists really do make an impact, and we're world-renowned for the research that we do, and I just wanted to plug them a little bit. So just coming back to the main point of all this is the one reason why measles is extremely nasty is because of its contagiousness or its infectiousness. So this, working on the second aspect of what makes measles really nasty, relates to how it impacts our immune system. Our immune system is really composed of 2 distinct subsystems, something that we call the innate and adaptive immune cells. And you can see them here on the left and the right. Innate immune cells function as kind of non-specific antiviral infection system. And to give an analogy, it's kind of like a simple deterrent house alarm system. Whereas the adaptive immune cells function as highly specific anti-infection system with long-term memory. It's kind of like a house alarm with facial recognition that deploys traps against its intruder. And I was going to use some imagery. Everyone's probably watched the movie Home Alone. And we can remember this scene kind of in the middle part of the movie where Kevin discovers that he's being watched. His house is being watched, and he wants to pretend like there's people home. He wants to use it as a deterrent. So he sets up a train with Michael Jackson in the window to go around and basically kind of warn off, non-specifically, the thieves that are plotting against him. That's an example of kind of what the innate immune system is like, whereas the adaptive immune system is later in the movie when he knows his house is being taken over. He uses traps and weapons to try and fight off the intruders, and that's what our adaptive immune system essentially does. What makes measles really bad is it actually infects and replicates in both the innate and adaptive immune cells, those cells that protect us, and it compromises their function, resulting in something called immune suppression. And this is essentially like cutting off the power to your alarm systems. So when you have immunosuppression, that leaves you susceptible to other infections, viruses and bacteria. And that's why measles is bad, is because not only does the measles virus infect, but it also renders you susceptible to other infections. And this is extremely dangerous for children, as well as the immunosuppressed that are operating on a partially developed or partially functioning immune system. It takes that threshold and lowers it even lower, making them extremely susceptible to further infections and disease. So measles is nasty because of its contagiousness and its ability to suppress immunity. So how do we stop the measles virus? So currently there are no antiviral drugs that can stop measles. There are no drugs out there that we've developed that are able to stop this virus once it's gained a hold. The most effective strategy involves training our immune system to recognize and defeat the virus through vaccination. It's kind of like I want to run a marathon in a few months. So I go out and I'm going to train every day so that I can hopefully cross the finish line. So the vaccination is sort of along the same lines. With the first dose of vaccination, we receive 85 to 95% protection against infection. And with that second dose, it boosts it up to 97% protection. So how does the measles vaccine actually work? Well, the measles vaccine is a type of vaccine known as a live attenuated vaccine. It was actually, and this is the most common form of the vaccine, was isolated from an infected 11-year-old child at boarding school named David Edmonston in Boston, Massachusetts in 1954. And this is known as the Edmonston B strain. And so once this virus was collected, the researcher Enders proceeded to weaken the virus by repeatedly growing it actually in chicken cells, which measles normally doesn't replicate in. Normally, measles only replicates in humans. But in very specific circumstances, we're able to put it into chicken cells and have it grow a little bit. And over time, it grows better and better. And this is actually called the Pasteur approach, and it was developed by Louis Pasteur in the late 1800s. And this is a very, very common strategy in which to take a live virus and make it weak. After many, many, many rounds of growing the virus in these chicken cells, the virus undergoes changes and adaptations that prevent it from replicating in human cells. You're basically forcing it to replicate in these cells that it's not designed for, so it adapts and it replicates, but now it doesn't like to infect human cells. So the reversion of this virus to the original strain is basically statistically impossible based on all the changes that have to happen. It's almost like lightning having to strike 10 times in the same spot within the same day, which just isn't going to happen. And then finally, when we introduce this vaccine into our into our bodies, our immune system makes really short work of this attenuated strain, and we acquire immune memory to measles. And so the measles vaccine is often given with the mumps and rubella vaccines, also called the MMR vaccine, which some of you may be familiar with. So how does the vaccine actually work? In this instance, the vaccine is represented by this cute little character here, and the immune system is this police officer. Innate immune cells of the immune system, including macrophages and dendritic cells, take up, digest, and display small bits of the measles vaccine on their surface. Adaptive immune cells, called T cells, recognize these small foreign bits as vaccine or virus, something foreign, and they become activated and memorize the structure of this surface, these antigens. The activated T cells promote the development of B cells that produce antibodies which bind and activate the antigen from the vaccine. And most commonly in measles vaccines, the most effective antibodies develop against the hemagglutinin protein on the surface of the virus, right here. If the antigen is detected again during exposure to, say, a real infection, the T and B cells are ready to pounce into action, produce more antibodies, and prevent the infection. And because the interaction between the measles and hemagglutinin and hemagglutinins receptors, including SLAM, CD46, and Nectin-4 are so specific, kind of like a lock and key, any changes to the hemagglutinin structure through virus drift or evolution would essentially prevent the binding and infection. And this structural handcuff basically is what enables the vaccine to provide durable immunity against the measles virus. So just to kind of wrap up this kind of molecular look into measles and measles virus, the measles virus is a highly contagious airborne pathogen, perhaps the most contagious virus out there. It can survive in the air for hours, can affect diverse cell types, and cause immunosuppression. And this is why it's so dangerous. And its ability to do this results in the varied and potentially lethal outcomes that are associated with measles infections, including pneumonia, blindness, ear infection, diarrhea, adverse pregnancy, neurological disorders, and death. And immunity to the measles virus through vaccination or prior infection profoundly reduces the risk of subsequent infection and adverse outcomes. At this point, I'd like to thank you for your attention, and I'd be happy to take any questions. Okay.
So we're going to take a 5-minute break for coffee and snacks. It gives you a chance to use a QR code to upload any questions, and we can field both sets of questions, clinical, basic science at the end, and have a little bit of a discussion with our second speaker as well. So with that, please join us in the atrium for some snacks and coffee. Thank you. Okay, I think we'll start into our second half here. So it is with great pleasure I get to invite our second speaker to the podium. So tonight we have Dr. Franco Rizzuti, who is a public health and preventative medicine specialist and a clinical assistant professor within the Cummings School of Medicine here at the U of C. He is in the Department of Community Health Sciences and is also the president of the Canadian Association of Physicians with Disabilities, and in this role is an active advocate for the association. And so, changing the slides. Okay, next slide. Second here. This one. Okay, perfect. Is an advocate for others with in the DEI community and ability spaces. He's a passionate advocate for disability rights and addressing structural barriers. In addition to clinical work, I mean, I think we can see that Dr. Rizzuti has dedicated his life to service. He has extensive experience as a medical leader, serving as the past president of the Canadian Federation of Medical Students, the Professional Association of Resident Physicians of Alberta, the Graduate Student Association of the University of Calgary, and chair of the Alberta Graduate Council. He's also served on the boards of the Canadian Medical Association, the Alberta Medical Association, Canadian Resident Matching Services, Resident Doctors of Canada, and the Board of Governors of the University of Calgary. So this is an individual who cares about our community. We are very fortunate to have him here tonight, and I'd like you to welcome Dr. Rizzuti to the podium.
Thank you so much, Craig, and thank you to the Snyder Institute. So I know we talked about a land acknowledgement at the start, but I always find it's really important for every presentation I do to just be mindful, pause, and think about the land we're on. So I am a white settler. I have the privilege of growing up here in Treaty 7, trained at the University of Calgary. But I think whenever we're doing work, right, and especially public work, population level work, it's really important to be grounded and mindful of the populations we serve. This is actually a photo couple weeks ago I took out in Kananaskis of the Northern Lights. And so I think just really important to think about the nature and, again, the people on this land. So I'm going to dovetail a little bit to Dr. Leidal's talk. And really, I want to talk about 4 things tonight. So a bit more about what is measles. Well, I'll add in and sprinkle in some clinical context. Why should we care about the circulation we're seeing these measles cases? Talk maybe a little bit about how did this happen, and then what can we do about it? So, you know, as you know, measles is highly infectious. So this is that same reproductive number, or R naught, as we talk about in the epidemiology biostat space. And I put a couple comparators here for you folks. So, you know, we have Ebola, so very, very serious fatal pathogen, but its replication number is 2 to 3. So this requires direct contact, so direct physical person-to-person contact. One Ebola case can infect 2 to 3 others. We have flu, SARS. In the middle there, we see with these kind of middle reproductive rates of 1 to 4 to 2 to 5. The reason I like using these is we think about flu season, and we think about how many thousands of cases we have, how many thousands of people are seeking healthcare utilization. And if we look at it from an epidemiologic perspective, we know that means there's tens of thousands, if not hundreds of thousands, who are exposed to influenza, develop influenza in the community with an R naught of 1 to 4. And then we have measles, 12 to 18. So the number we tend to say is 1 measles person in a room will infect 15 susceptible individuals. Again, that 2-hour air drop time, so you don't even have to be in the room, right? Someone with measles could have been in the room, left, and within 2 hours, still the ability to contract. So this is a great overview from 2020 by Lexano et al. And it really gives a good sense of the overall pathogenesis of measles. And I'll walk through this bit of a busy figure. So as you know, measles has that incubation period of about 10 days. Sometimes it can be as short as 7, all the way up to 21 days. So that is after you were exposed, it incubates, completely fine, going about your business, no symptoms. And then we start with what we call this prodromal phase. That's when you feel like you have other respiratory viruses or illness. Cough, maybe, some runny nose, some red eyes, but otherwise feeling okay. And we tend to see a fever. We then have the rash onset. And as Dr. Leidal said, starts on the head and neck and moves down. It is a pathognomonic rash. You see it, you think this is measles. And then, you know, continues on towards recovery for some, sometimes complications. Now, what's interesting is as we think about it, people will be exposed. So it's one of our 3 truly airborne pathogens. So it stays in the air for 2 hours. You breathe it in. It binds to the memory immune cells in the lungs, and then can go throughout the body. Now, what's really interesting about that rash is truly a sign of how thoroughly measles has infiltrated the body. So we see the rash, that means it's infiltrating skin cells, it's infiltrating actually cells of the bladder, infiltrating cells of your mucosal linings and other organs. So this is a virus that can get into truly every cell line in the body. And that's part of why it's so infectious. And you can see it's most infectious, that green kind of pyramid, most infectious from 4 days before the rash. So when people might still be feeling okay, maybe a bit of fever, cough, until 4 days after the rash. So we have about a full week period where we would say people are going to be infectious with measles. And this is the important piece. It's not just a little rash. It's not a virus or an illness that we go through in childhood. It is a very, very serious condition. And I'll talk a little bit more about it. The pictures on the left give a sense of what this rash looks like on fairer tones or lighter tone skins as well as darker tone skins. And again, really important when we talk about rashes to think about that inclusivity. What does measles look like on different skin tones? Because sometimes, we have seen people, especially in the developed world where we haven't seen measles in decades, potentially miss a case because it just looks different. So I've broken it down by common, some severe, and then these long-term. So you've heard ear infection and diarrhea. About 1 in 10 folks who have measles will develop that. That ear infection can lead to permanent deafness or loss of hearing. We can see hospitalizations, about 1 in 5 unvaccinated folks, US data. So we're looking at developed world, right? Good healthcare systems will be hospitalized. Pneumonias, about 1 in every 20 children with measles will develop pneumonia. Some of these children so severe they will be in the ICU. They will potentially be intubated. It's a severe presentation. You've heard about the encephalitis, a little bit more rare, 1 in 1,000. But this can again be quite severe with potentially long-term and permanent complications. Death, we tend to say 1 to 3 out of every 1,000 children who become potential for it to be fatal, unfortunately. And then who we're really worried about is pregnant women. So we'll talk a little bit more about this as we go, but measles vaccine is a live vaccine. Means that if you're unimmunized or unvaccinated, immunosuppressed, and contract measles or are exposed, we can't give you the vaccine as post-exposure during pregnancy. The only option is a blood product, immunoglobulins, to help curve the severity, but there is real risk to pregnant women and potentially to their unborn child. So severe. You've heard about subacute sclerosing panencephalitis. The interesting piece with this, and it's why it's so hard to actually nail down the full number, it develops anywhere from 6 years to 20 years later. And often, especially in an era historically where we didn't have comprehensive, fully integrated electronic medical records, hard to know is this measles related or not, but can be quite severe. And overarching all of this, which I don't think we talk nearly enough about, is that measles will almost universally end up with some variant of what we call immune amnesia. So highly variable. Of everyone who has measles or contracts measles will end up with some amount of immunosuppression for a period afterwards. It might be for weeks. We've seen people with lifelong immune suppression. So let's think about any prior vaccine preventable disease you were immunized for, any prior infection you had, there's a chance that your immune system forgot how to be protected against that. We've turned off that part of the alarm system. And so that's a piece where you can recover from measles, but you can still have that severe immune loss. You heard about Roald Dahl. I'll give you the exact quote that he had at the beginning of BFG. So Olivia, my eldest daughter, caught measles when she was 7 years old. As the illness took its usual course, I can remember reading to her often in bed and not feeling particularly alarmed about it. Then one morning, when she was well on the road to recovery, I was sitting on her bed showing her how to fashion little animals out of colored pipe cleaners. And when it came her turn to make one herself, I noticed that her fingers and her mind were not working together, and she couldn't do anything. I asked, "Are you feeling all right?" She said, "I feel all sleepy." Later that day, she became unconscious and within 24 hours died from measles encephalitis. That is the unfortunate history we have historically with measles. It can be a very, very serious disease coming on very quickly. And as you heard, not a lot we can do outside of supportive management within the system. So why do we care? I talked a little bit about the clinical picture, but I'm going to pull this up to a population level. So measles and rubella are part of a WHO ongoing elimination eradication strategy. So this came out in 2021. It's our 2021 to 2030 global reduction in measles. Looks at reducing, ideally having a world free or eradicated of measles and rubella. I'll skip to the punchline. We're not there yet. We were doing really well. Many, many nations achieving elimination status, and we're starting to see year by year erosion of that progress. Truly comprehensive plan, bringing together stakeholders, government partners, community partners, healthcare partners, to work across the continuum from prevention, primary care, into the health system to reduce the burden of measles globally. So I'll take us on a little bit of a journey through the past. So this is measles data publicly available from the Health Canada website, looking back to 1924, the first time we started tracking this. And you can see from 1924 to 1958, so while measles was considered endemic or occurring in Canada, we were, fluctuating somewhere between, say, 20 to, at the highest, in about the mid-1930s, 83,000 measles cases a year. Now, I haven't accounted for population growth. So keep in mind, these are Canadian populations that were less than half of our current population up until 1958, where this was, kind of what we saw for measles. If we then look forward, so all the way up until 2023, the first vaccine was launched in 1963. That was a not live, so a killed vaccine. The live vaccine came out a little bit later, and Dr. Leidal talked about that. We had a universal one-dose program in 1974, and then moved to 2 doses in the mid to late 90s. And you can see the dramatic change we had in our measles rates, right? We went from 83,000 a year to, in the 10 to 20,000 with 1 dose. Once we moved into a 2-dose immunization program, we went into, at one point, 2,000 in the late 90s when we had that move into the 2-dose. And then the highest we had seen in Canada up until recently was 752, is in a large measles cluster we had in the mid-2000s. So we went from 83,000 cases a year to, a grumbling amount, mostly due to importation. You saw this slide. This is reported every Friday by Health Canada. So last month, or last week, just under 12,000. This data is lagging. You can see this is the week of April 19th, so we're lagging 3 weeks. So this tells us what we were at in Canada 3 weeks ago. By the time it's reported in 3 weeks' time on current state, we'll probably be over 2,000 cases in Canada. Again, highest we've ever seen since we had measles elimination achieved in 1997. This, hot off the press this afternoon as of noon, so Monday through Friday, noon, Alberta Health updates its numbers. If you were watching this on Friday, we had 210 cases. Today, Alberta Health is reporting 265, so an increase of 55 cases over the weekend. A little bit of a lag, not as much of a lag in this data. Unfortunately, it's anticipated that we're going to continue to see cases come through. Now, if we think back to that incubation period, 7 to 14 days. So cases we're seeing today, or reported today, were probably diagnosed in the last week, and they were exposed potentially 2 or 3 weeks ago. So again, it gives us a sense of, even if these numbers start to slow, it's reflecting what happened a while back. Last week, the Public Health Agency of Canada updated its risk assessment for measles in Canada. So this is the second risk assessment it's done. So pretty much the takeaway is there is a moderate to high risk of seeing ongoing spread in Canada in the next 6 months. The highest risk is going to be in low or partially or unimmunized populations. So the risk to folks who are vaccinated, probably less. But still this means fairly high burden of disease, means a lot of strain in a healthcare system that's already quite taxed. And, I'll say a little bit, when we have a measles case in hospital, they are on airborne precautions. So that means they're in a negative pressure room, one of the few that hospitals tend to have. It means if for some reason they come in and they're not identified, not masked, not put into a negative pressure room, this potentially means anyone who was in that emergency department could have been exposed. In the last few cases the province has had, I can say a single case in hospital can result in somewhere between 300 to 600 contacts. Every single one of these people has to be phoned, immune status assessed, and we have a very short period of time of what we can do. We have 3 days from contact to give them vaccine if they're not immune, to hopefully prevent them from developing it. And we have 6 days for really high-risk folks that we could offer that blood product of an immunoglobulin to, again, hopefully kind of mellow out or mitigate the severity of the disease. Other than that, supportive measures if someone does develop measles. So how did this happen, right? I've talked about the epidemiology, I've talked about the virus, so how did this happen? So we know every year we're going to see sporadic importation of cases. People travel elsewhere where measles is endemic, they may be exposed, they return to Canada. And when we have sufficient population level immunity, we may see the odd case, we might see a secondary case in a close contact, but we don't see outbreaks in clusters. When we don't have that level of immunity, we end up seeing the spread that we're seeing now. Within Alberta, data as of a couple weeks ago, there was at least 10 discrete and separate introductions of measles into the province of Alberta. So 10 of these sporadic importations that, because of lower than ideal immunity, and I'll speak to that in a sec, led to a number of cases, secondary, maybe tertiary cases coming from that. So again, publicly available data. This is Alberta Health's reporting of immunization data, recently updated, so includes last year. So this looks at 2 doses of MMR, so measles, mumps, rubella, containing vaccine by age 2. The provincial target, or vaccine schedule, I should say, is 1 dose of MMR at age 12 months, a second dose at age 18 months. So the thinking by looking at 2 doses by age 2 gives a bit of a buffer, but gives a sense of folks on schedule for immunization. The target rate is 95%. That is what Alberta Health, the government, funds and targets towards. You can see province-wide, we're at 80%. The urban zones tend to be a little bit better, rural zones a little bit poorer. A lot of that is due to access challenges. Rural zones, more geography, maybe have to go a little bit farther. We know there was a lot of disruption during pandemic and afterwards some delay. So it gives us a sense of, if we look at on target, 2 doses by 2 years, we're not anywhere close to that 95%. And the reason we need 95 goes back to that R naught. So the thinking is, if 1 measles case can infect 12 to 18 people, if we have 95%, stats being what it is, maybe 1 person in that room might be susceptible. So we just are working off of reduction of potential exposures. We also report 1 dose by age 2. There's reporting of 1 and 2 doses by age 7. And then kind of the catch-up piece is looking at how many folks have 2 doses by age 17. So this gives us a sense of what's the population level. So overall, we're at 92%. You can see we've been a little bit better, covered in the 93, 94%. In Calgary, about 94%. Again, rural zones a little bit less. And you would say, oh, it's only a few percent. But when we're talking about such a contagious virus, such as measles, that few percent is why we're starting to see the breakthroughs that we're seeing. So a good study, about a decade and a bit old now, but looks at the risks of measles, which I talked about. So that otitis media, ear infection, diarrhea, pneumonia, that SSPE, encephalitis in that first column, and then looks at what we would say common or known reportable adverse outcomes or events due to immunization in the bottom. And what the study started to look at is kind of that pros and cons of immunization risk versus the actual disease. And when we're in an era now of seeing potential spread, ongoing spread of measles, important to look at some of this and get this information out to the public so they can make their own informed decisions. So we might be thinking, okay, what's the benefit of this comprehensive vaccination program? What does it mean, right, to the public, to policymakers? So really good study, about a year old now, published in the Lancet, so highly reputable journal, looking at 50 years of data of enhanced immunization programs and the impact on health. So a bit of a busy slide, but I'll walk us through it. So looked in the 50 years back, so going back to the 70s, the first one is looking at the number of deaths averted, so folks who did not die due to immunization. And we have all the common vaccine program pathogens. So pertussis is there, tuberculosis, Haemophilus influenza. Measles makes up the largest portion, and measles alone is, by the modeling, by the math, peer-reviewed journal, 94 million lives have been saved because of measles immunization. If we look at years of life lost, so very common health economic outcomes of what's the cost benefit, how many lives did we save? 5.7 billion life years have been gained due to measles immunization. And then if we look at full years of life of health, so this is an assessment of not a disability, so someone without any disability or complications, about the same, 5.8 billion years. So huge impact on global health outcomes, regardless of what health economic measure you use, attributed to an immunization program. So what can we do? You heard some of it this morning. The minister spoke about the province's strategy, but it is really a multi-pronged approach. Like everything in public health, it is going to be a comprehensive approach. It's not just one tool. There has to be lots of tools, lots of partnerships. So there will be some outbreak measures. These tend to be, we try to limit, public health tries to limit the measures put in place. There is a founding principle in public health ethics of least restrictive means. So if it means that we can achieve a goal by communication, communications can be done. If there's a need to have some sort of isolation, that would be considered. But public health does not go to the biggest tool in the toolbox upfront. It always starts small and then gradual and proportional increase. So there will be outbreak measures. Comprehensive communication. We know that measles is a pathogen folks may not have heard about. We haven't seen it. When I was in med school, we did not see measles cases in the ward. So it's one where we do need a really comprehensive, broad-reaching comm strategy, social media, traditional media, across languages. So we need to communicate. We know we are living in an infodemic. We know there's a lot of myths and disinformation, a lot of myths. There's going to be a lot of work needing to be done to just provide information to combat what we're seeing. Immunization, as you heard, is really the only tool we have in the toolbox to prevent disease and to prevent adverse outcomes. There is some early data starting to suggest high-dose vitamin A for hospitalized patients to, again, mitigate the severity of the disease. It is not preventive. It's not going to prevent someone from getting measles. Immunization is the only piece. And then truly collaboration. This is, the old idiom of takes a village to raise a child. It's going to take the entire community in a village to really achieve measles elimination status, which is what Canada achieved in 1997. And I'll end us on the note of the Canadian clock started last October. We had a number of cases in October. So every time there's a measles case in Canada, that nation has a year to demonstrate that they can prevent community or secondary spread. That's why if you look at Public Health Ontario, some of the reporting, we talked about a number of cases until October last year. So Canada has until October 2025 to demonstrate we have measles contained. If not, it runs the risk of WHO pulling back on a measles elimination status. And so if we look at G7, OECD indicators of health outcomes, achieving elimination status of highly communicable severe pathogens is one of these markers. So it speaks to Canada regressing on health outcomes. And so again, it's going to take collaboration, going to be requirement of working with leaders across the board, community leaders, public leaders, politicians. And with that, we're happy to take questions. Thank you.
Oh, okay, perfect. So I'm going to, first of all, I'd like to thank both speakers, and if we could get Dr. Leidal down for some questions. Unfortunately, we've got a dead mic today, so we're stuck with only the online questions. I do apologize. There is the QR code. If you have a question, scan it. We can type it in. They'll come up here. So first of all, first question, please.
Yeah, so the first question is there a rapid test for measles? So there's 3 ways to test for measles. So there's measles serology, so blood, and it's an immune assay, looks at do you have immunity for measles. That is not a rapid test, has to be done in the lab. And then we can also do PCR by either a nose or nasopharyngeal or urine specimen. So all of these right now are in the lab, accredited, validated labs. At present, there's not a Health Canada, nor is there an FDA-approved rapid test for measles. So right now we are really leveraging our lab colleagues. So a big kudos and thanks to the lab folks who are doing heroics right now on all the specimens they're processing.
Perfect, thank you. Probably next question's best for you as well.
Yeah. So question is that if you're born 1959, do you need another dose? So the current Canadian guidance is to consider, and I'll speak to first non-healthcare workers. So anyone who's not a healthcare worker, if you're born before 1970, you are considered immune just due to the prevalence of circulating virus at that time. Anyone after 1970 requires 2 doses of vaccine or documented prior measles infection to have immunity. If you're a healthcare worker, we forget about that 1970 piece and say you need 2 doses or documented evidence of having prior infection. So if you're a healthcare worker, you need 2 doses. If you're not sure, you can phone 811. They will help assess immunity and can book folks in. But for the rest of the public, if born before 1970, considered immune.
Perfect. I see we have a few more questions. I'm going to throw, moderator's prerogative. I want to throw a basic science question out just to make poor Dr. Leidal sweat too. I think for me, one of the striking pieces of both of your presentations is we don't have any therapies. So it's prevent it or ride it out, essentially, and whether that requires hospital support. Are there any areas where we see some progress or some opportunities for antiviral or harnessing our immune system to better fight this if we've missed the opportunity to vaccinate? And maybe I'll turn over if you have any. Well, you want to, Mike? Yeah, sorry.
Boost our immune system is through supplementation with vitamin A, and I think because measles has largely been thought to be eradicated, a lot of investment from the biotech industry hasn't been in developing new antivirals for measles because we already have the answer of what we should do. And so the answer is to go out and get vaccinated so you're not susceptible to these diseases. So I would say that, well, I think people will probably, with this new outbreak, look into the potential for things that may aid, like immunoglobulin therapy that can help mitigate things somewhat. Largely, I think the onus is going to be on people getting vaccinated.
Thank you. Okay, so we'll maybe come back to the clinical side. Do we know the cost that this is impacting the healthcare system? Do we have a ballpark? So somebody's hospitalized for measles. What is the average cost of looking after that?
Yeah. So it's a good question, and It's tough to put an exact number, right, on how much it costs, but I'll walk us through a journey. So if a patient presents to an emergency room, there's going to be the cost of services for the physician for that emerge visit. You can say that's probably going to be in the range of $1,000 to $1,500, assuming they get discharged. A lot of folks are actually quite sick when they present, and so that's going to be a hospitalization. Depending what figure you use, and I'll just throw it a rough ballpark, $2,000 a day is not an unreasonable kind of, pulling a figure out of the sky is a rough number of what it costs for a person to be admitted. So $2,000 a day. That doesn't include if they're in an ICU and all the supports required. It doesn't cover, costs of, say, high dose vitamin A therapy. It doesn't include lab testing. It doesn't include if they have any sequelae or other complications. So, going to be variable, but there is a cost on that. What these numbers do not account for, if there's any contacts, all the hours for our infection prevention and control practitioners to contact trace, our public health nurses to contact trace. Usually a single contact history takes, if you're really efficient, 2 hours, realistically closer to 4 hours of time. And this is a trained, expert nurse with public health training. So again, think 400, 600 cases times that number of hours, we can get a sense of the overall system cost.
Great, thank you. The message or the questions are coming in fast and furious here, so keeps moving. Like, stop moving. So perhaps we can we'll pivot a little bit to the vaccine here, and what is the average, or what is the percentage of vaccine non-responders? I think the evidence is that this is a pretty good vaccine, and that most people are responding. But as a follow-up to that, there was a really good question here that has now come off the screen. Is it possible to be vaccinated just for measles, or is it always maybe I'll...
Yeah. So question about vaccines. So in Canada, there are 2 licensed measles-containing vaccine. So mumps, measles, rubella, MMR. And then recently, it's about a decade old now, mumps, measles, rubella, varicella, MMR, VAR. The current schedule in Alberta, many other provinces have similar, has MMR, VAR for children. So that's the default vaccine product offered to children. There is the ability, if a parent wants, to request MMRV. Or MMR alone. So mumps, measles, rubella alone for their child. It's always a discussion with the public health nurse and provider talking about your preferences. And that's part of every routine immunization well-child assessment. Seeing how the kiddo's doing, seeing about vaccine preferences, and the team will work to support. So 2 vaccine products, MMR, and then the newer product, MMR VAR. And again, the recommendation would be MMR VAR, but there is the ability to offer MMR alone.
Thank you. So I'll just take a look. So I think we can take the percentage of non-responders off as well. Yep. Please, yeah.
Yeah, I mentioned I was discussing with somebody just in the break. Was it some of the populations that maybe we can't give the vaccine to, the pregnant women, people who are immunocompromised? There's actually been some recent developments potentially using similar technology that was developed for COVID, using, rather than the whole virus, whole attenuated virus, parts of the virus, a specific protein within the virus called F, as a potential antigen to try and drive immunity against the virus, so that we can protect some of these more vulnerable populations that might not have or be ideal for the live vaccine. So I think that's something that's probably up and coming, and potentially people might be interested in, because it really doesn't involve a full virus.
Let's see here. How do we combat disinformation? Man, that could be an entire night, couldn't it? I think it's a fair question. I think it is important to listen to concerns. There was, as a follow-up to this, there is a question about, can we make some information available on social media? So there is a handout here tonight. We can have the Snyder Institute put that up on our social media feed, and then people can distribute that further. And that has direct links to the provincial guidance, as well as some facts. But This is a tough subject. It's something that a number of us spend several hours and perhaps therapeutic beverages getting through. But rather than dig into my own trauma that my therapist has under control, I'll maybe hand it off to the experts and please.
Yeah. I can take a stab. So, I talked about mis and disinformation as part of the strategies, right? And really it goes back to making information available. I think one thing we've seen in the last 5-10 years is really that democratization of health evidence and health data. Putting it out into the public space, having open access journals, having sessions like this to really make information available. It's also why, public health likes to be able to engage, communicate, and talk about things, right? Ask questions. If it's seen as preaching from the ivory tower, it doesn't work, right? We know we need to be in communities. We need to meet folks where they're at. And I'll go a step, a little bit, because I know we talk about this all the time, is it's also talking about overall reasons for vaccine hesitancy or vaccine reluctance. And that's not that folks are anti-vax or have their beliefs. That's not the premise of vaccine hesitancy. Vaccine hesitancy looks through 5 complex domains of reasons why. One of these is confidence in the product. One of these C's is complacency. We hadn't seen measles. We saw a trickling numbers. Reasonable for folks to think this is not a pathogen we see here, right? That's one of the C's. Convenience. If you have to drive 2 hours to go get a vaccine appointment and they're only open business hours, that's really tough. So we know there's work to be done on access. There's pieces about overall social and community kind of responsibility. And then there's personal, communication as well, right? So how do we get information? So we know that if we work through these 5 C's, if we provide information and you allow individuals to make their own decisions, it's really embracing that whole patient as part of the care team, right? And so have the discussions. And that's part of why it's 2 doses by age 2. We know there's going to be some flexibility. We know life happens in targets. It's not 2 doses by age 18 months. It allows for life to happen. So again, put information out there, and it takes the community to really get information out there.
Thank you. So maybe moving over to vaccines, there was one question on the screen about is Alberta now offering vaccines to those 6 months of age and up? And that was an announcement this morning. That is not part of the 2 doses. That's in addition to the 2 doses. So that's really speaking to the prevalence of measles in the community and the risk to the youngest Albertans. So, whoever posted that is obviously right on the news. So that is 12 hours old, but the recommendation now is vaccine can be offered. The other side of that spectrum, is there a booster dose? Do we need one? And maybe I'll hand that off to Dr. Leidal to talk about booster, but I'll also throw one more on that, and that is for individuals who can't be vaccinated. So we did see if you're exposed while pregnant, we've heard this term, you offer blood product. So maybe you can fill us in a little bit on how that fills the gap of vaccination.
So just addressing that latter question first, in terms of this blood product, it's actually the antibodies that our immune system makes. We're able to purify them and isolate them and give them to patients who can't maybe or maybe not ideal for generating their own immunity. And so if you supply the antibodies that our immune system naturally makes, they work in the same way. They bind around the virus, they block it from getting into your cells, and you're protected. The problem is that since you can't make it, you constantly have to supplement in order to keep it effective. And in terms of a booster, the booster for those that potentially would be interested, that is essentially the live attenuated vaccine. But I would say that really probably the best thing to do is to check to see whether you have circulating antibodies. Do the serology test to make sure that you're maybe not immune before really seeking out a booster situation, because a lot of people will still be immune. I think it's best to check first.
Okay. How do we make provincial politicians responsible? Well, that opportunity does come up about every 4 years. So that will be my official answer. Unofficially, we can talk later. But officially, people do respond, right? I mean, there are decisions made, and it is up to us to provide feedback on those decisions, and the best way to do that, because we live in a democracy, is voting. Perhaps building off the updated guidance today, so we are seeing doses being available now to younger Albertans. We did hear that there will be new vaccine clinics opened, expanded hours, expanded access. Perhaps this bottom question: can pharmacies administer this? And
Yeah. So a good question about immunization processes right now. So right now, who's eligible to give immunizations is set out by provincial government policy. So the current immunization program guidance right now does not permit MMR in pharmacies. So right now it's predominantly going to be public health nurses who will give MMR-VAR vaccines. There's a few special cases, but typically the main reason is due to cold chain. So MMR is not we have good supply of MMR, but if you think of how many doses of, say, influenza we go through every year, the amount for MMR is significantly less. And so there's a short shelf life. And so until we're seeing, until there's a need for a mass immunization program, it's trying to focus and give these to the clinics who have a lot of capacity still. So folks are willing, you phone 811, there is capacity. Clinics are running, they will run extra clinics, book later if need be, but there's capacity. So it's restricted right now due to cold chain, so safety reasons for the vaccine, and then just to make sure that there is supply for these clinics and depots to be able to supply. So I know there is ongoing immunization strategy discussions happening at the government level, and we'll look to government to kind of expand who's eligible and make changes to that. But right now, it's provincial program policy.
thank you. So I'm just keeping an eye on the time. We have time for a couple more. So perhaps I can even address the bottom one again. In the announcement this morning, we are anticipating and be launching this week a public information campaign. So this will be social media, this will be TV, radio, multi-language. So much as we had seen during the peaks of COVID, we did have positive impact with messaging, making sure people know where they can get reliable information. This isn't about forcing vaccines. This is about making answers available to people that are vaccine hesitant or have questions. So that will be launching this week. Keep your eyes peeled. Share it, particularly the social media, with people in your circles that might have questions. Perhaps to wrap the evening, we'll throw one more, and I'll get both of you to tag team this. And this is the infamous Dr. Wakefield. So this is for those that aren't familiar, perhaps we can fill in a little more information. This was a clinician who had a manuscript published in the early 90s that appeared to demonstrate a link between this particular vaccine, measles, mumps, rubella, and autism. Years later, it was determined that this paper was entirely fabricated. And in fact, if you try to find the paper now, it is permanently marked with retracted. Again, we could probably have a 3-hour chat on everything that went wrong with that particular study, including working on children with no ethics whatsoever, conflict of interest, his own rival company, you name it. But it lives on, and it's still in social media. And perhaps I'll get both of you to provide your perspectives of what that one paper has done to our efforts for not just measles, mumps, rubella, but vaccination in general. I mean, Andrew, if you want to start.
Sure. It's really undermined a lot of the effort that scientists, physicians have gone to try and verify that vaccines are safe and effective. And just from my own scientific perspective, I mean, the work, as Craig points out, was retracted, but it wasn't rigorously done in the way that all of us scientists approach the questions, where you examine a hypothesis and you look at the different, in this instance, does the vaccine cause autism? Well, you would check in patients or children that received the vaccine to check the rates of autism that were observed there. And then obviously you would check the the rates of autism that were detected in the patients that didn't receive the vaccine. And actually, Dr. Wakefield didn't check the rates of autism that were detected in the people that didn't receive the vaccine. And so just by a pure scientific methodological approach, it's totally, it's kind of an abomination from a scientific perspective. So it's unfortunate that people got their claws into it and have brandied it about to justify why that vaccines potentially contribute to an important illness, but hopefully through communication and events like this, we can describe why that that research was debunked.
And I'll just add, so, as folks said, it was a study that had significant structural and methodologic issues. There were conflicts of interest not disclosed. There was actually fabrication and fraud in the results. Results were made up. So it has been, all of that has been reviewed. The paper has been retracted. And there have been numerous studies that have actually said this is the data. But as we know, it only takes one loud voice to amplify that misinformation, and it takes thousands, if not millions, and a lot more hours to actually then, counter these myths or that false information. I'll speak to, though, from a system perspective. So if we think right now about vaccine trials have a variety of considerations. It's why now to do vaccine trials, it is always a multi-stakeholder, highly collaborative study. You have basic scientists, you have clinicians, you have public health folks, you have epidemiologists. It's so that we don't inadvertently fall into, attributing correlation or causation when it may only be correlation, where we've actually looked at these confounders, looked at controls, looked at all that. And then every vaccine, every approved health product goes through multiple phases of trials before it's approved. And then we do ongoing safety studies afterwards. And in all of the safety studies we have in the, now, if we look back to the 60s when MMR was put out, if we go back and, decades worth of data, what we see is what I showed of tens of millions of lives saved, years of life saved by this vaccine. And that has kind of validated the safety of the vaccine. So I think I'd leave it there. Again, very, very problematic study. We have great rigor in science, but that was one that unfortunately at the time slipped through.
And maybe I'll add to that. So we've heard the science behind it and even the systems behind it. Personally, even as an immunologist, as somebody who studies this for fear of dating myself 30 plus years, when I had kids, it still resonates in the back of your mind, right? I mean, even though you believe it's not true, it's not true, still gets us asking a question of our pediatrician, right? And if that can have that impact on me, who is trained in looking at the data, it is really impossible to overestimate the impact of that on the general public, right? Even if you want to be vaccinated, there's that little voice in the back of your head. So this damage continues, and it is a uphill battle and will continue to be so for years to undo what a single bad study has done to the world. So on that wonderful positive note, I really do want to thank our presenters today. So Dr. Leidal, Dr. Rizzuti. I would also, like to extend a very heartfelt thank you. I mean, this happens throughout the course of the year and now for 10 years, and none of it happens without our support staff, right? So the people at the Cummings School of Medicine, particularly the Snyder Institute, put these together every month. Make sure you have snacks, make sure the coffee's hot, make sure these guys show up on time and have slides, right? So I think it's critical. Also our online support, post-pandemic, that has been a wonderful tool. We've been able to reach further people. So if you could please join me in thanking our full support. As I mentioned earlier tonight, This is the biggest crowd we've seen now in a few months. And again, thank you, given the weather, the hockey. Hopefully you're out still for the third period. We do appreciate this. This is something we enjoy doing, and it's only enjoyable because you're here and participating. As I said, this is the end of our 10th season. We are really excited and looking forward to season number 11. If you have topics you would like to see addressed, please reach out. Please let us know. If we can pull together some interest, we'll be able to launch our new topics starting this fall. So with that, once again, I'd just like to thank you and wish you all the best of evenings.